Thank you for a kind introduction and congratulations to the whole team. A very excellent and well-crafted agenda, I must say, and it gives me an immense pleasure to welcome everybody later in this evening, especially on a Friday evening, pre-Holy festive season, for a very important discussion on a very important topic, that is especially metastatic non-small cell lung cancer. And as I start my talk, I will request the team to share the slides on my behalf. I will keep on saying next and next, if that's convenient and fine. So decoding treatment options for EGFR metastatic non-small cell lung cancer has been a very talked topic, and we know that worldwide data across all over world, if we look at it, in both sexes combined, lung cancer is the second most commonly diagnosed malignancy with around 11.4% of the total cases. It's a leading cause of the cancer death, 18% of the total cancer deaths. And if you look at the number of the new cases in 2020 in both sexes, around 11.4% is the lung cancer cases. And very important are the parameters which help us in determining what treatment choice should be there as a first-line treatment options in the advanced EGFR metastatic non-small cell lung cancer. Next slide, please. So we have a plethora of options, as especially what the data has been there for a FLORA trial, and we have seen an unprecedented, next slide, please. We have seen an unprecedented remarkable benefit with the, especially when we started 10 years back, we had option of only Geftinib. The chemotherapy was the standard option probably during that time. So there was an IPAS study where the Geftinib scored superiority over the chemotherapy option, as you could look at it. Then came the optimal study where the Erlotinib showed a superior option as compared to the chemotherapy. Then we had Afatinib as the Lux Lung trials showing a superiority over the chemotherapy options. And then we came with Decometinib, and recently the FLORA trial showing a maximum PFS advantage of 18.9 months. So on an average with the chemotherapy options, I believe we don't have much to decide, but yes, these parameters, especially the progression-free survival, the overall survival, the response rate, the presence of the brain metastasis, the quality of life, and also the how many patients are able to receive the second subsequent line of treatment is very important. Next slide, please. If you look at the options of it, to me, you could have the startling difference between the trials. As you could see, with more and more years, we have seen newer and newer molecules coming, and with that, we can easily say that yes, with unprecedented advantage, FLORA stands apart. So if you look at the progression-free survival, I believe FLORA trial has shown an unprecedented maximum PFS advantage of, as you can see, as compared to the rest of the TKIs. The Lux Lung trial where the Afatinib, you could see the curves were exactly over each other. The Archer 1050, again, the curves separated later in the part, but very important was all brain metastatic patients were excluded out of it. But with Osimertinib, you could see that there was an immediate separation of these curves. So this molecule definitely is different as compared to it. And 19% of the patients were included which had a stable brain metastasis. So showing that there is an early separation and consistent separation of the curves as shown by these curves of the FLORA trial. Next slide, please. And you could look at the response rate. If you could see across all generations, Osimertinib shows the highest response rate with the longer lasting duration of responses. As you could look at into the data, nearly 80% of the patients had some response rate, and nearly 3% of them had a complete response rate. And also very important is the duration of response. So not only there is a response, there is a durability of this response. as compared to 12 months with afatinib, 14 months with decomitinib. Osimertinib shows the highest duration of response, also with 17 months for it. And if you look at the overall survival again, the next slide, please, the final curves you could see, there was a 0.8 difference between the two. That is, there was a 20% reduced chances of deaths when you give osimertinib as compared to the comparator EGFR TKIs. So 38.6 months versus 31.8 months, as you could see. And you could look at median OS of more than 3 years. You could look at OS. Osimertinib patients were more likely to alive at the second and third year landmarks. If you look at the second year landmarks, 75% of the patients who were given osimertinib were alive, as compared to less than 60% of those where the comparator EGFR TKI was given. And if you look at the 3-year landmark, again, you could see at 55% of the patients were alive, as compared to less than 45% of the patients to the comparator TKIs. And first time across all the molecules right now, we have an EGFR TKI that has translated a PFS advantage into an overall survival advantage. The Lux Lung 7 and the ARCAR 1050 trial, you could see in Lux Lung 7, again, afatinib failed to show an improved overall survival. Next slide, please, as compared to the geftinib arm. And if we, next slide, please. Next. Next, next. Next. So if you look at the afatinib trial, it was a failure in terms of the statistics as well as clinically. You could see those curves exactly crossing over each other. In ARCAR 1050, the decomitinib trial, even though keeping the hierarchical gatekeeping procedures as the hypothesis testing, the overall response rate was not statistically significant, and hence the formal testing of the overall survival could not be conducted. And that's where when they concluded and they published their results, they said that exclusively those patients who had a brain metastasis, they were excluded from the trial. Although there was an improvement OS in the numerical terms of view, but 34.1 months for the decomitinib as compared to 26 months. But trial wasn't designed for the same. The trial was designed to first prove it overall response rate, having a significant p-value, and then jump to overall survival. Next slide, and next slide. So if you look at the long-term efficacy data of it, osimertinib stands apart. 28% of the patients were still receiving osimertinib at 3 years, which was 3 times more than the patients in the comparator arm. 22% of the patients who were receiving the osimertinib had also were on the treatment while the data cutoff was there. So if you look at the FLORA trial, again, osimertinib demonstrated a superior systemic progression-free survival benefit regardless of the CNS disease status at the study entry versus the EGFR TKI. The CNS events also occurred frequently lesser in the osimertinib arm as compared to the other arm. You could look at the 6% versus the 15% in the comparator arm. If you look at the hazard ratio, around 53% reduced chances of brain metastasis and also systemic progression as compared to giving a standard of care for the same. In intracranial CNS efficacy, if you look at it, again, the hazard ratio 0.48, meaning a 52% reduced chances of intracranial CNS progression as compared to the comparator EGFR TKIs. So there was a significant CNS response to the first line osimertinib in patients with EGFR metastatic advanced non-small cell lung cancers. You could look at all these data and you could look at the careful treatment selections. There was a systemic response rates, there was an intracranial response rates, there was a decreased duration of the there was increased duration of response, and also a reduced chances of intracranial progression when you give osimertinib upfront as compared to the comparator EGFR TKIs. Next slide. If you look at the again adverse events, which is very important as we discussed, the safety of the drug with decomitinib, 63% of the patient had a grade 3, grade 4 adverse events. With afatinib, there were nearly 31% of the patients who had a grade 3, grade 4 adverse events. with osimertinib, that figure was around 18%. So these are the side effects which requires drug interruption, drug delays, or a dose uh, reduction. And you could see that these were significantly higher in decomitinib and afatinib arm as compared to the osimertinib arm. The typical EGFR TKI effects, that is the class effects, that is diarrhea, maculopapular rashes, pustular rashes, dermatitis, all were frequently higher in the decomitinib and afatinib arm as compared to the osimertinib arm. Next slide and next slide. And if you look at the dose reductions, again, 41.9% required it in Lux Lung with afatinib, 67.4% required in ARCER 1050 with decomitinib. In FLORA trial, only 5% of them required a dose reduction. And if you look at that, the quality of life, you could see the global quality of life was improved with the FLORA trial, as you could look at the clinically and meaningful, significant improvements in the same. So to conclude, 1 out of the 3 patients of all EGFR patients treated with a one or second generation EGFR TKRs are able to receive a second line osimertinib if we look at the rate of the T790 mutations, as it is not possible to predict who will develop a T790M resistance. 7 out of 10 patients who start on a first and second generation TKI will not able to receive second line osimertinib. And if you look at the access to the second line therapies also in the lung cancer across all trials, you look, it is nearly 30% is the 30 to 40% is the dropout rate of each of them. If you look at it, you look if you look from IPASS to the Lux Lung to the Optimal to the ENSURE trial. Next slides. So if you look at the real world evidence, also less than 50% of the patients put on afatinib acquire a T790M mutation resistance for it. And if we have to sequence the EGFR TKIs, we have to sequence it very cleverly, because if we start with the first line TKI, the first generation TKIs, and then treating those on EGFR T790 might not be a good sequencing, because we are not smart enough to figure out as who will able to develop EGFR T790M mutation and who will not. And not everyone will be enough to receive an additional treatment, because 30% of the patients don't receive any subsequent therapies. Tissue and liquid biopsies, we always know, is an issue with the lung cancers, and osimertinib has a significant survival benefit as a first line agent. So we have to look also at the sequencing factors also, the toxicity to the first line drugs, the occurrence of the T790 mutations, the sites of the progressions, the concurrent morbidities, and the patient choice. Next slides. So if we look at the real world evidence of also it, we have a beautiful flower trial, which was done with the first line osimertinib in the real world setting with an interregional prospective studies. All patients who had an EGFR mutated across globe were recruited, and they were looked as whether the trial data was transferred into the real world data. Exactly similar was the real world data also. So there was around 63% of them having an exon 90 deletions, 21 exon mutation was there in 43.7% of them. The time to the treatment discontinuation was standard 25 months, and the median time to duration was significantly higher as compared to the real world, as compared to the other comparative EG5s. There was a significant higher median progression-free survival, around 19 months of them. And if you look at the median time to duration in patients with less than 3 or 3 metastatic sites was significantly higher, 21.4 months, as compared to those with a much extensive disease. Also within intracranial disease, the drug seemed to have a good PFS advantage. So of osimertinib real world flower study confirmed the effectiveness and safety of the data in the real world, although you could see that there was more thromboembolism which were occurring in the osimertinib as compared to the other in the clinical trial world data. We have the quality of life check also for it, osimertinib fact, as the OSI-FACT study, where the osimertinib as a first line was introduced again in a real world setting, and you could look at the same situations, the overall response rate 76%, the disease control rate 94%, the exon 19 deletions 50%, 45% was exon 21 deletions. The median PFS was again 24 months, and you could look at the separation of the curves exactly similar. And also the reason for discontinuation was a pneumonitis for one 12.8% of the patients with grade 3, grade 4 being around less than 0.7% being a grade 5 event. So PFS after the first line osimertinib treatment in the real world situation was favorable. The discontinuation rate due to adverse events was less. Also was the Mykonos study, where again the real world study of the patients with EGFR as a first line metastatic situation was tilt. Next slide, please. And the real world data supports the effectiveness of the osimertinib in this. So also at the interim analysis, you could look at around 18.8% of the patients were able to receive the second line as a TKI, whether it could be a immuno with TKI and chemos as the options. So all across the guidelines, you could look, be it the NCCN guidelines, the preferred agent of the category 1 is the osimertinib first line in those who have an exon 19 deletion or L858R mutations. If you look at the ASCO living guidelines, also osimertinib monotherapy is preferred as the first line, strong level of recommendation. So over to the last slide, osimertinib is the only EGFR TKI which has demonstrated a clinically and a statistically significant improvement in the overall survival. The median overall survival benefit of greater than 3 years sets a new benchmark of osimertinib and provides a window of opportunity for the management of the patients with stage 4 non-small cell lung cancers with sensitizing mutations, reaffirming its importance as the first-line therapy. FLORA is the first-line EGFR TKI that has translated in the EGFR metastatic situations as a PFS benefit into an overall survival benefit. Nearly 30% of the patients remain on osimertinib at 3 years. Osimertinib is the only drug which can be given in patients with brain metastasis, NT790 mutations. Osimertinib is the safest and the least toxic drug among all the available options. And sequencing can't be considered as the best strategy, as almost 70% patients are not able to receive a second-line subsequent treatment. These data confirm that osimertinib as the first-line standard of care in metastatic EGFR patients positive non-small cell lung cancer. I rest my case here and hand over to the organizers. Would love to answer any questions if there are any.